This is a video in clinical medicine from the New England Journal of Medicine.
In the human body, only the retina allows the examiner to achieve direct visualization of the central nervous system and the vasculature. Therefore, the fundoscopic examination is important in the detection of certain systemic diseases and diseases that primarily affect the eye. For non-ophthalmologists, the direct ophthalmoscope is the preferred instrument for examination of the retina. The retinal examination is part of a complete physical examination. It is particularly important in patients with a history of such systemic diseases as diabetes, hypertension, and atherosclerosis. Patients with the human immunodeficiency virus, HIV, or the acquired immunodeficiency syndrome, AIDS, are also at increased risk for retinal diseases. Evaluation of the retina may reveal the initial evidence of diabetic retinopathy, hypertensive retinopathy, macular edema, glaucoma, or age-related macular degeneration. Diagnosis and appropriate interventions can help preserve sight and prevent disease progression. Urgent indications for direct ophthalmoscopy include clinical suspicion of increased intracranial pressure, occluded retinal vessels, and retinal detachment. Any of these conditions or sudden changes in vision constitutes an ophthalmic emergency. The patient should be seen by an ophthalmologist immediately or should be sent to the emergency department. Think of the pupil as a window through which you can view the inner structures of the eye. The light rays from the ophthalmoscope pass through the cornea, pupil, and lens to focus on the retina, producing an upright, magnified image. The retina is located on the inner surface of the globe, opposite the pupillary opening. The color should appear red, orange, or brown, and varies from person to person. The direct ophthalmoscope consists of a handle, which contains the power supply and a light source, and a head, which contains the viewing window and lenses. The on-off switch adjusts the brightness of the light. The apertures include a large circle, a medium circle, a small circle, and a slit beam. It is best to use the ophthalmoscope at 80 to 90% brightness, with the small or medium circle, to reduce the patient's pupillary constriction. The ophthalmoscope contains a range of lenses with positive and negative diopters that compensate for refractive error in the examiner and the patient. If the patient has hyperopia, then the retina will be closer to the pupil than normal. If the patient has myopia, then the retina will be farther away from the pupil than normal. Adjust the lenses by turning the dial. Negative numbers focus on objects that are farther away, and positive numbers focus on objects that are closer. First, explain the procedure and tell the patient that direct ophthalmoscopy has virtually no risks. The patient may experience discomfort from the bright light shining into his or her eyes. Ask the patient to sit with legs uncrossed. Have the patient remove eyeglasses if present. Contact lenses will not affect the examination and may be left in place. Darken the room to maximize pupillary dilatation. Note that the room is not darkened here for the purposes of the video. Designate a point at least 1 meter away for the patient to look at. Patients are better able to fixate on an image or object than a blank wall. Switch on the ophthalmoscope light and begin with the 0 diopter lens. You may use your contralateral hand to elevate the patient's upper eyelid. Always use your right eye to examine the patient's right eye, and your left eye to examine the patient's left eye, to avoid being nose to nose with the patient. Start by locating the red reflex, which is the reflection of light from the retina. Hold the viewing window of the ophthalmoscope to your eye. Position it about 30 centimeters from the patient's eye, slightly temporal to center, and shine light into the pupil. A diminished or absent red reflex could indicate an obstruction, such as from cataracts. Follow the red reflex as you gradually move closer to the patient. Turn the dial clockwise to decrease the diopters until you focus on the retina. Hold the ophthalmoscope as close to the patient's eye as possible, since this will optimize your view. You will be able to observe only a small area of the retina in the viewing window. Tilt the ophthalmoscope to visualize different areas. Find and follow a vessel as it increases in caliber, going back to its origin at the optic disc. The optic disc is located about 15 degrees nasal to the center of the retina and should appear yellowish-orange. The optic cup is a pale central depression in the optic disc. Axons of the retinal ganglion cells exit the retina at the optic disc to form the optic nerve. In the retinal vasculature, veins are thicker and darker than arteries. The fovea is the area responsible for the highest visual acuity. It is temporal and slightly inferior to the optic disc, and is surrounded by a more darkly pigmented region, called the macula. The cup-to-disc ratio, or the ratio of the optic cup diameter to the optic disc diameter, is normally 0.3. A higher cup-to-disc ratio, particularly a ratio above 0.5, may indicate glaucoma. Swelling of the optic disc can have multiple causes including papilledema, optic neuritis, and anterior ischemic optic neuropathy. Any of the conditions associated with swollen optic disc requires an emergency workup and evaluation by an ophthalmologist. Next, examine each quadrant of the retina, tracing vessels away from and back toward the optic disc. You may ask the patient to look in different directions to facilitate visualization of the corresponding part of the retina. For example, if you wish to view the upper right quadrant, ask the patient to look to the upper right. Non-proliferative diabetic retinopathy may cause microaneurysms, exudates, dot blot hemorrhages, and flame hemorrhages. The proliferative form of diabetic retinopathy features neovascularization. Hypertension can result in changes in the color and caliber of blood vessels, giving them the appearance of copper or silver wires. Arteriovenous nicking refers to narrowing or disappearance of the vein on each side of an arteriole. Cotton wool spots result from axons that were damaged by infarction and local ischemia. Occlusion of retinal arteries is usually caused by atherosclerosis or emboli and requires an emergency workup for systemic stroke. The appearance of a cherry red spot in the fovea is a sign of central retinal artery occlusion. Central retinal vein occlusion may result in retinal hemorrhages. An easy method of locating the macula is to ask the patient to look directly at the ophthalmoscope light. You may observe the foveal reflex due to pitting of the fovea. Because of discomfort from light shining directly onto the fovea, it is best to save this part of the examination until the end. The wet as opposed to the dry form of AMD involves vision loss caused by choroidal neovascularization. In direct ophthalmoscopy, the non-dilated pupil provides the clinician with a limited view of the retina. It is best used for screening rather than diagnostic purposes. If there is clinical suspicion of ocular disease, refer the patient to an ophthalmologist for a dilated fundus examination. Patients with cataracts may have a diminished or absent red reflex. To obtain the best visualization of the fundus, try reducing the size of the aperture in order to minimize light scattering. It may not be possible to visualize the fundus in patients with dense cataracts. Refer patients with dense cataracts to an ophthalmologist. Although the fundoscopic examination is challenging for beginners, it becomes easier with practice. Take time to familiarize yourself with the ophthalmoscope before examining patients. Dim the room lights to maximize the dilation of the pupils and improve visual contrast of the fundus. Remember to first elicit the red reflex, as the red reflex indicates successful illumination of the retina. To locate the optic disc, make sure to approach the patient about 15 degrees temporal to center. If you are unable to visualize the retina, you may make small adjustments in your angle relative to the patient's visual axis. Technological advances include the development of instruments that facilitate examination of the retina by non-ophthalmologists. Some of these devices contain cameras. However, these new devices are not yet widely available. Direct ophthalmoscopy is an important screening tool that can be mastered with practice. It may be performed in minutes during the general medical examination and poses virtually no risks to the patient. Ophthalmoscopy allows the general practitioner to evaluate the retina for pathological changes, particularly in patients with common systemic diseases such as diabetes, hypertension, and atherosclerosis. Ophthalmoscopy can also help identify ophthalmic emergencies that require immediate attention.